Hi everyone, good afternoon. Thank you so much for coming to this presentation on medical cannabis. My name is Jonathan Zaid and I'm the founder and executive director of a nonprofit organization called Canadians for Fair Access to Medical Marijuana, or CFAM. And CFAM represents patients' rights, and over the past 6 months we've been working closely with the Arthritis Society as well as the Canadian AIDS Society to make sure that patients' needs are prioritized as part of legalization. And the Arthritis Society, furthermore, has made a call for funding from the federal government for research, specifically for medical cannabis trials. So we're working hand in hand to try to make sure patients are prioritized and that research is established from a government perspective financially as part of legalization. And I want to commend the Arthritis Society for the step they've taken to do this, because there are a number of organizations, large charities, that haven't stood up for medical cannabis patients' rights. But the Arthritis Society has really taken a stand and said this is medicine and that we need to consider cannabis as medicine, and seen the tremendous impact it has had positively on many people suffering from arthritis and arthritis symptoms. Today you're going to hear from possibly the top 2 researchers in Canada on medical cannabis, Dr. Jason McDougall and Dr. Mark Ware. Dr. Jason McDougall will speak first, more on the basic science perspective, and then Dr. Ware will speak more on the clinical perspective. Dr. McDougall received his Ph.D. in joint physiology from the University of Glasgow and subsequently completed his postdoc training in Canada, Germany, and Spain. He is currently a professor in the departments of pharmacology and anesthesia at Dalhousie University. Dr. McDougall's research focuses on the neurobiology of pain and how the nervous system can cause arthritis. His research examines the role of cannabinoids in arthritis, pain, and inflammation. Dr. McDougall currently is the chair of the Arthritis Society's Scientific Advisory Committee. Dr. Mark Ware is an associate professor of family medicine and anesthesia at McGill University. He is the Director of Clinical Research at the Allen Edwards Pain Management Unit and at the McGill University Health Centre. He's the co-director of the Quebec Pain Research Network and executive director of the Canadian Consortium for the Investigation of Cannabinoids. I'd also like to thank the sponsor for today's session, which is Bedrocan, a licensed producer of medical cannabis. So at this time, I'm going to ask Jason to start his presentation, and I'll just step in when there's a couple minutes to give Jason a flag. But other than that, we're going to then move on to Dr. Ware's presentation and then take questions at the end. Thanks.
Great. Thank you very much, Jonathan. Good afternoon, everyone. I'd like to thank the Arthritis Society for giving us this opportunity today to hopefully try and educate and maybe debunk some myths surrounding cannabis and the potential benefits for the use of medical cannabis for the treatment of arthritis. And I actually want to start today by maybe debunking some of those myths and telling you some of the things that I'm not going to talk about. So first of all, this is not joint inflammation. Let's be quite clear on that. This is not what I'll be talking about today, not joint inflammation. Anybody who thinks this is joint pain is really in the wrong room and shouldn't be thinking that this is joint pain. And quite clearly, this is not joint replacement at the bottom here, this bong at the bottom. But what I will be trying to talk about is the medical, the science of cannabis. There really are fascinating plant and fascinating group of compounds that are found within the cannabis plant. And this was just taken from the cover of Time magazine in May last year. And it really does sum up the whole area of medical cannabis, and that it's highly divisive. I mean, I think no more than any other drug out there, we can see that there's really quite polar opinions associated with cannabis. It's curiously underfunded. It is quite remarkable that there is a severe lack of funding has been put into the potential benefits as well as potential side effects and hazards of medical cannabis. And I like this last one, strangely promising. And what I'm going to show you today is some strangely promising data that we found in the preclinical realm. So using our mice and our rats, okay, we don't give them joints and we don't make them smoke like this little fella, but I'm going to give you some evidence of why cannabis has some benefits associated with it. But first of all, a bit of history. So around about 8000 BC was when there was really the first indication that the hemp plant was being used for textiles and rope, making of rope and clothing, etc. And then we jump ahead to around about 2700 BC when Shen Nong, who was considered the father of traditional Chinese medicine, he was a curious guy. He took 365 different plants and started eating them and chewing them, and then made notes about what sort of effects they had on him. As you can imagine, it took longer than the 365 days because there were certainly some recovery periods associated with some of these plants that he took at random. But interestingly, when he took cannabis, he found that the gout, he was suffering from really severe gout. He found that the gout pain subsided by following taking cannabis. The first indications that cannabis came to North America was back in 1611 with the first settlers. And in the 1800s, it was really interesting. There was this explosion in cannabis research, particularly in Europe. And what was going on in Europe at the time was the chemists were having a heyday. They were working for the textile industry, and they were taking various different plants and different shellfish and extracting chemically different compounds to dye clothes. And some of the health guys thought, well, this is really interesting. Let's see if we can start extracting some of the compounds from plants to see if they have any therapeutic value in various different diseases. So there's this huge explosion of research back in the 19th century. In 1850, believe it or not, cannabis was part of the US pharmacopoeia, so it could be prescribed in the US. And in 1935, there were actually 28 cannabis-containing therapeutics that were available for doctors to prescribe their patients. 35. And there were a number of different research and development programs, including Eli Lilly here. And then it all went horribly wrong. And it was taken down by one single man, a man called Harry H. Anslinger. And he was a politico. He tried to demonize cannabis completely. He used magazines. He used to publish in various different magazines these really nasty articles about cannabis and the dangers of cannabis, and that it's really coming from these Mexicans that are bringing it over the border, and Chinese people as well, who are making us addicted to opioids. It was sound familiar to a particular politician, maybe that's that's about today. And so he introduced this Marijuana Act. And what that did is he successfully shut down all research and development, and it became too expensive to prescribe or use any of these medical cannabis, and it all completely disappeared. Just one man and his views. And it really set us back decades in research and development in cannabis. And it wasn't really until late 60s, 1970, where Raphael Mechoulam at the Hebrew University in Jerusalem, he was able to identify a chemical that was found within cannabis, delta-9 tetrahydrocannabinol, otherwise known as delta-9 THC, and that was, of course, the psychoactive component of cannabis. So what actually is cannabis? There are three different types of cannabis. It's a flowering plant, and there are three species. There's Cannabis sativa, Cannabis indica, and Cannabis ruderalis. And if you look and delve into the different chemical constituents of cannabis, there are over 480 different chemical entities in there. It's a real hodgepodge of a lot of different chemicals. And we can break those chemicals down into cannabinoids, the terpenes or the terpenoids, and the flavonoids. And these terpenes and these flavonoids are what give cannabis their very significant smell and odor and taste. But they may also have certain therapeutic values. We just don't know yet. So there are 112 different cannabinoids. The famous one, of course, is THC, the psychoactive component. There's also cannabidiol, which is extremely safe. It's non-psychoactive. You can eat grams of this stuff. It's absolutely fine. And other ones like cannabigerol. And these chemical cannabinoids are found in the oils, which are secreted by the trichromes, which are small little glands, which are found at the base of the flower of the female plant. And this is a nice pretty picture of a cannabis trichromes there. Okay, so the cannabinoids, I've just spoken about the phytocannabinoids, so from the plant cannabis. Then there are man-made, synthetically made within the lab. These are the syntheto-cannabinoids. And then there are endocannabinoids. These are the ones that are naturally present in our body. So you may be familiar with endorphins, being the endogenous opioids. Well, we also have endogenous cannabinoids as well. And the most famous one is a chemical called anandamide. Anandamide takes its name from the ancient Sanskrit word ananda, which means pure bliss. And okay, let's get into a little pharmacology. There are two receptors that these cannabinoids can bind to. They're called CB1 and CB2. CB1 is primarily located on nerves in the brain. It's the most abundant receptor within the brain. And it's also on peripheral nerves, so in our joints, and I'll show you in a moment that there's these CB1 receptors in our joints. And then there are CB2 receptors, which are mainly associated with the inflammatory cells in our body. So we asked a question a number of years ago, are there any cannabinoid receptors in our synovial joints? And so we did some experiments looking for this, so the CB1 receptor, first of all. So we looked at the synovium, because that's where there's the highest density of nerves within the joint. And what you're seeing, what these arrows are pointing to are nerves that are present within the synovium, and they've been stained with a particular marker for CB1, and you can see they're nice and glowing. So we do have these CB1 positive type nerves in our joints. We're also the first to show, sorry, this is maybe not quite clear in this light, but these little green dots here are CB2 receptors found within the synovium of the joint. So there are CB1 and CB2 receptors within synovial joints. So that's pretty interesting. So what are they doing there? How can we activate those cannabinoids within those cannabis receptors within our joints to see if it'll modulate things like pain and inflammation? So let's think of a little basic neurobiology. So we have special sensory nerves in our joints and in our muscles. These are sensitive to mechanical stimulation. They tell us that we're moving around, and we know that our arms are in certain positions, or our legs are running or walking. And these nerves go through the spinal cord and then up to our brain. And during normal sort of movement, these nerves send electrical impulses at a pretty low and regular rate up towards the central nervous system. And the brain interprets this electrical activity as movement. However, if the joint is injured or there's an arthritis within the joint, these nerves now become really quite highly sensitized, and the frequency of the firing is dramatically increased. And it activates particular regions of the brain so that you get that ouch sensation when you feel the pain. It also affects other regions of the brain that says, okay, if I put my hand in that hot fire, I know it's going to be hot next time, so I need to avoid it. And it also the very, very strong emotional component associated with pain. Pain is not just a neurobiological event, it has a significant effect on our psychological well-being. So let's just zoom in this little place in the spinal cord here, and hopefully we can get the video to work. So here's a sensory nerve coming from the joint, and you can see the regular firing of the nerve during normal movement, but during painful movement, that frequency of firing is dramatically increased. And what happens on this is a nerve in the spinal cord, and what happens with that continuous bombardment is that even if the tissue heals or it's feeling good, there's still changes that our central nervous system, our brain and our spinal cord are very, very plastic. And so they keep thinking that there's pain going on, even though the pain may have actually resolved within the joint itself. So we wanted to look at this electrical activity in some of our models of arthritis. So here's some electrophysiology that we published about 8 years ago now. So what I'm showing here are these electrical events, the electrical signals in response to a normal movement of the joint versus a painful movement of the joint. And if you go and count all these spikes or all these electrical events, you can see that during painful movement, there's a dramatic increase in the firing rate. And so the brain would interpret that as pain. Now, look what happens when we give a single injection of a cannabinoid into the joint. So this is not going into the central nervous system. This is trying to activate those receptors that are in the joint itself. And we do exactly the same movements. And you can clearly see that the number of electrical events has dramatically decreased with both normal movement as well as a painful movement. So we've been able to block that pain in the joint itself with a cannabinoid, and it's not getting into the brain, so you're not getting any of those psychoactive side effects associated with it. So local injection into the joint reduces joint nerve activity, and that equals a reduction in joint pain. Okay, I mentioned earlier on there are endogenous cannabinoids, the naturally occurring cannabinoids in our body. We wanted to see, is there a way that we could exploit this system to see if we can reduce pain and inflammation. So the interesting thing about the endocannabinoids in our body is that they're only produced when there's an injury or there's an inflammation. So if the tissues are all okay and all settled, there's no endocannabinoids. As soon as you injure yourself or there's a disease process going on, then there's an accumulation of endocannabinoids within the inflamed joint. Now you think, well, okay, if I've got inflammation and I've got these guys which are supposed to be able to reduce pain, why are they not reducing the pain? And the reason is that there are enzymes that are also released which come along and chew up those endocannabinoids in the joint. And so they never get a chance to do what they're supposed to do. And they disappear. What if we blocked that enzyme? What if we blocked Mr. Pac-Man there from chewing up those endocannabinoids? The idea would be that we block the enzyme, and now those endocannabinoids can naturally accumulate within the joint, and let's see what it can do to pain and inflammation. And this is what we found. So again, looking at some of these electrical events, doing some electrophysiology with painful movements, and this is a normal control joint. This is just a normal joint. And these are where we did our recordings from. And you can see there's absolutely no effect of the enzyme blocker. It's called a fatty acid amide hydrolase enzyme blocker, if you're interested, or FAR for short. And it doesn't do anything. And that's what we'd expect. This is a normal joint. There's no endocannabinoids for it to work on. Now look what happens when we look at an osteoarthritic joint. With a single injection of this enzyme blocker, we can dramatically decrease that electrical activity that's coming from the joint, and it's not getting to the brain. We've got a reduction in pain. Okay, so I've spoken a little bit about pain. We have a strong interest in the lab about pain, but we also have an interest of whether they're involved in inflammation as well. So you may have heard that cannabinoids and cannabis could have anti-inflammatory properties. We wanted to test that in our animal models to see if it has indeed anti-inflammatory effects. Okay, so what I'm showing here is a diagram, a cartoon of a blood vessel. This is the inside of the blood vessel, and inside the blood vessel here, we have a couple of white blood cells or leukocytes. And normally these guys are just flying through the blood vessels and not hanging around at all. They're just flying through there. However, when you have an inflammation, there's a signal comes from the blood vessel which tells this white blood cell to start rolling. It sticks, and then it is slowly moved out of the blood vessel into the tissue, so maybe into the synovial fluid, where it will then release all its chemical mediators, and those chemicals can cause inflammation, and we know they can cause pain. So could we try and block the inflammation and the pain through this pathway? And again, I've got another video here. This is what I'm going to show you is a blood vessel from a knee joint of a rat, and with an inflammation, and then we're going to give it one of our enzyme blockers to see if it's going to reduce the inflammation. So this is an inflamed knee joint. This is our control. So I don't know if you can see, there's a blood vessel, and all these little white spots are white blood cells flowing through the joint, and some of them are stuck to the side. Some of them are doing that rolling phenomenon I was telling you about. So this is clearly an inflamed. Now we gave our drug that reduces the breakdown of the endocannabinoids, and you can't see it even because there's no leukocytes actually being stuck to the inside of this blood vessel. Okay, so just to summarize, what I've hopefully convinced and shown you some experimental data from the lab using models of arthritis, that if you give a cannabinoid into the joint, locally into the joint, it can reduce pain. And if we block the breakdown of the endocannabinoids, we will reduce pain and inflammation in arthritic joints. And so cannabis, I put to you today that cannabis and the endocannabinoid system could be a very useful way of treating joint inflammation and joint pain. So I just want to thank people who've worked on the cannabinoid project over the years for the last about 11, 12 years now that we've been working on cannabinoids. And my collaborators at Eli Lilly. I'd like to thank these guys for paying the bills. And I will finish with my poem. I always finish with a little poem to try and put into context the things that I've hopefully talked and convinced you about today. And this is my poem. So when people ask me what's the point of putting cannabis in my joint, I tell them they should never hide from the total bliss of anandamide. Its use in vivo is somewhat fraught because its half-life is rather short. But block the enzymes that break it down and anandamide regains its crown. To alleviate arthritis pain and avoid the highs inside the brain, inhibit far in knees until it's CB1, joint pain nil. Thank you very much.
Thank you, Jason. You are a hard act to follow with poems and poetry, but I thank you for setting the stage so nicely for my presentation. So good afternoon, everyone. My name is Mark Ware. I'm a family physician. Thank the Arthritis Society for setting this up and really for allowing us an opportunity to help you understand the language of cannabinoids and cannabis and why we're so interested in this as a therapy. Because my job is to kind of dampen your enthusiasm a little bit, because in spite of all that you've heard, in spite of the potential that we have for these compounds to be useful, we don't have a lot of clinical evidence to show that this helps in patients. And I'd like to sort of explain to you a little bit about why that is and how we can do something to help. So I'm going to talk a bit about the clinical side. You've already heard from Jason really what cannabis is. It's a plant. It has these compounds in it which are interesting. And for a lot of patients and physicians, the question is, well, what does the research tell us? And some of you may have had experiences if you've talked to your doctors or you have family members that have asked doctors, and you get a wide range of responses from physicians who say, I don't know anything about it, or it's not legal, or it's, that's not, don't understand this, or, don't talk to me about it. So a lot of physicians really don't understand where we are with research. But for a lot of patients, what do I need to know? What is the knowledge that I should have about cannabis if I'm going to inform myself? And then I get asked a lot, what if I want to try it for myself or for my family members? What do I have to do? So I'm going to try and touch base on a little bit of this in the next few minutes. But first, why do we care so much? Why is this such a big thing? Why is it in the newspapers every day? Why is it on the cover of Time magazine? What's so special? If it we wouldn't be having these kinds of discussions and special seminars. And one of the reasons is that cannabinoids are not really an accepted medication. And I'm going to show you some exceptions to this, but for the most part, cannabis, marijuana, is not an accepted medication. It's not prescribed. It doesn't have an approval. It doesn't have a number. You can't get it in the pharmacies, although we've just heard from Shoppers Drug Mart that they'd like to see that happen one day. But cannabis is not this medicine. So that's one challenge. We talk about cannabinoids on the one hand, but herbal marijuana is not a medicine. And there's this issue about recreational use. People use marijuana, cannabis as a social or recreational drug. And many of you may have done so when you were younger or still do. But it has this recreational or social use, which contrasts with its medical use. And for a lot of people, when they hear medical cannabis, they get concerned that really it's just recreational use. And people are saying they use it medically, but in fact, they really just want to get high and enjoy their movie or their Friday night. And so this creates a contrast. We don't have that kind of problem with Tylenol. There's a stigma associated with it. You know, Bob Marley, the hippies and the 60s and the marijuana leaf. And this is all, the language of marijuana is fraught with a culture. You know, people are potheads. And you have this whole idea of cannabis having this stigma associated with it. And a lot of people are concerned about safety. And does it affect our brains? Does it affect our ability to drive? Does it affect our ability to remember things and function properly? And a lot of people are concerned about secondhand smoke. What if somebody in my house or in my apartment or when the neighbor is smoking and I can smell it coming in my window? Is that affecting me? Does that trouble me? So, walking down St. Catherine Street here in Montreal, just yesterday, you can smell it. And I'm wondering if I, walking closely enough, I can maybe get a little bit of a hit from the guy in front of me. But people wonder about this kind of thing. And again, not the sort of thing that we often worry about with other conventional medicines. And I think Jason covered this very nicely. But cannabis has been used, and you dig in the history of cannabis. Arthritis is one of those things that keeps popping up as a reason why cannabis is being used. We've had experience with patients using cannabis for arthritis, and I'm going to tell you a little bit about that. And I want to kind of talk a bit about what the future might be for this. But first I want to refer, this is from 1600. This is a quote from an English herbalist who, and it goes back in the 1600s, all they really had as medicines were various different herbs and roots and leaves. And in blue, you can see that, and this is really interesting, he writes that the decoction of the root of cannabis eases the pains of gout, right back to our Emperor Xin Yang, the hard humors of knots in the joints, the pains and shrinking of the sinews, and pains of the hips. This is 400 years ago. But what's interesting is the decoction of the root. Now, I'm not aware of anybody that's actually taking cannabis roots and stewing them up and seeing what's in there. And that might be something one day we should be looking at. If these guys were right, they were actually pulling the plant up, throwing away the flowers, and taking the root of the plant and chewing that up. So maybe interesting that we're looking at the wrong end of the plant. The fresh juice mixed with oil and butter is good for anyone burned with fire once it's been applied. So lots of colorful ideas. But I think, we need to remember that these are, and there's a nice picture close up. Those are the cannabinoids coming off on the flower, and those are the molecules that Jason was telling you about. And really the top one, the THC, is the one that we've focused most on in the clinic. We've had it since 1970. It's been looked at and studied in a number of different pain conditions. The other ones, cannabinol and cannabidiol. CBD is the one you may be hearing about for childhood epilepsy. So people are using this to give children with very bad epilepsy syndromes, and it's the one that appears to also potentially have some inflammatory effects in arthritis that people are very interested in looking at. So it's THC and CBD are the two major ones that we'll be talking about today. And this is something I think Jason showed you the history of cannabinoids and kind of very nicely showed you how it was done. What I want to do is throw on top of that map opioids. So opioids, long time ago, opium, that was how we used them. Then we discovered the ingredients, and we now have this knowledge about the receptors. Well, cannabinoids are very similar. You heard the trajectory that Jason's pointed out. What I want to show you here is that we're just 30 years behind the whole process. We discovered the receptors later. We're discovering the enzymes later. We're discovering the way this works later. So perhaps we're a little bit just behind the schedule, but within the next 10 to 20 years, we'll have better medicines based on this system. We're just kind of now becoming aware of it. So what do we have in the clinic at the moment? And many physicians may not be aware of this. I think over the last 15, 20 years or so, a lot more physicians are becoming aware of what these compounds are. But you can actually now get a prescription for a cannabinoid medicine today in Quebec, in Canada, and these are the ones that we can get. Dronabinol, which is THC, pure THC, used to be available in Canada on prescription. I understand that in the last year or so, it's been taken off the market because the company wasn't selling any of it. Doctors weren't prescribing it, wasn't being used, and the company has to spend a lot of money to make these available, put them in pharmacies, and if it's not being used, they're simply going to stop putting it out there. I still don't fully understand why we weren't using more of it. I think it was expensive. But I think it got kind of taken over by this compound, nabilone or sesamed, which is a prescription cannabinoid. It binds to the CB1 receptor that what Jason was telling you about very, very tightly. So it's a very powerful cannabinoid drug. And it's approved as a chemotherapy drug. And we've started using this, and we've studied it in fibromyalgia patients. We've studied it for sleep and for pain, and we've looked at it for spinal cord injury, for neuropathic pain conditions. And this is a very interesting compound. It's what we call off-label, so it's not actually its indication. When you get it from the pharmacy, it will still say it's for nausea. But you can use these kinds of medicines off-label. And it's a very interesting thing. For people that are interested in exploring whether cannabinoids might help, sometimes your physician will say, well, let's try some nabalone first. And this is why. Because you can prescribe it. It's covered by the RAMQ in Quebec, so it won't cost anything. So you can use very small doses of this to see if your body responds to a cannabinoid medicine. And that's sometimes the first place that a physician will go to, and it does. It tests the cannabinoid system. It may see, and if you respond, if you get side effects to this, it may tell you that, listen, you know what, you may not be somebody that responds well to cannabinoids. I have patients who've tried this and it hasn't worked, or they've had side effects, but I've had some that have also responded really well, especially in terms of sleep. You use a small dose at night, helps them sleep better than it did before, or better than they were sleeping before, and sometimes that's all that it's been able to do, but for a lot of patients, that can be a very powerful effect. This drug, nabiximols, is a really interesting compound. It was developed by a British company who grew cannabis plants high in THC and another group of plants that were high in CBD, and they combined the two in a spray. So it's like a mouth spray that you spray into your mouth, and it contains equal amounts of THC and CBD. And it got approved in 2005 in Canada as a treatment for multiple sclerosis for patients with pain and spasticity with MS. And then more recently, it got approval for patients with cancer pain. So this looks like it's an interesting compound. It's got the two main cannabinoids in it. It's a spray into the mouth. It's very expensive. And it has a sort of a funny taste. It's got a little bit of alcohol and peppermint in it to give it some flavor. But it's expensive, and some people don't really like the taste. But it's available, and it's a prescription medicine. I'm going to come back. This is the only one that actually has been studied for arthritis at the moment. And that's available on prescription in Canada. If you have private insurance, sometimes they'll cover it. So that's another one that you should be aware of if you're talking with your physician about whether cannabinoids might be right for you. And then, of course, there's the herbal cannabis. And this is the medical marijuana program, and I'll talk a bit more about that right at the end. But this doesn't have a formal approval. As I pointed out, it's not a prescription drug. I can't prescribe it for somebody and they go to the pharmacy and get it. There's a special authorization process that you have to register with a company who then sends it to you, and there isn't really an indication. It doesn't have an approval for it, but people are using it for a lot of different conditions. And we'll talk a little bit more about that now. So cannabis as a plant, when you grow it, and the companies that are licensed by Health Canada grow a number of different strains or varieties of cannabis, and they contain different levels of THC and CBD. So this graph shows you on the one side THC along the bottom, and on the y-axis you've got the amount of cannabidiol. So plants, the little blue dots are the different species, and so you've got some that have a lot of THC. You've got some that are very high in CBD, and then you've got another cluster that are quite high in both THC and CBD in sort of equal amounts. And this slide from my friend in Vancouver, John Page, shows that really the average THC values in these plants that are coming from the licensed producers are quite high in THC. But what we're seeing is gradually people are getting more interested in the cannabidiol and the other compounds. So this is changing. This is a year old now, more than a year old. There are over 300 strains. There are 35 licensed producers now. So this is an area of botany that's really exploding. What we don't know as physicians at this moment is whether any one of those particular dots is better for somebody with osteoarthritis or rheumatoid arthritis or fibromyalgia or whatever other lupus, whatever other kind of arthritis. We just don't know yet whether this is going to tell us that some patients prefer one versus the other. But we're working on doing that now. We have a trial going on that I'll tell you about where we're trying to compare these different ratios of cannabinoids. But a long time ago, I asked patients that were coming into our clinic who were using cannabis for medical purposes about, what they used it for, why they used it. And so I highlight here some of the patients. So we're going from 24-year-old man with ankylosing spondylitis right up to a 68-year-old woman with rheumatoid arthritis at the bottom. And then, another rheumatoid, somebody with seronegative spondyloarthropathy, a mixture of men and women, a wide range of ages, different kinds of arthropathies. It doesn't tell us much, but we knew these patients were using cannabis to treat their symptoms. So we started saying, well, what's the evidence base? How do we study and prove whether this is happening? We looked at all the clinical trials, and as Jason was telling you, there's been a delay delay in research because of prohibition, because of the barriers to doing research. But in the last 10 to 20 years, you can see the dates on these trials from 2008, 2010, the earliest one is I think 2004. In 2005, the only study on this list for all the different cannabinoids that are available to us, the only one that's in an arthritis model is rheumatoid arthritis, done in 2005, and it's the only clinical trial that's ever been done on a cannabinoid in arthritis in a clinical population. And that's it. So this is why doctors say, well, there isn't enough evidence. There's no evidence in osteoarthritis. It hasn't been studied in patients with OA. And so for physicians to say, well, I don't have enough evidence, that's why. The studies haven't been done. But what does that rheumatoid arthritis study show us? Let's take a look at that in a little bit more detail. And I know that there's a lot going on here. What I want you to look at is that list of efficacy endpoints on the far left. And this is how, when we do trials, we measure the impact of a drug. And it could be any medicine. It could be an anti-inflammatory, it could be Tylenol, it could be whatever. But we look at people's pain levels. But we not just measure your pain on a scale of 0 to 10. What is your morning pain when you move? When you get up in the morning, you start moving. How much pain do you have then? How much pain do you have in the morning if you're not moving? If you're just sitting down, having your coffee, are you in a lot of pain? What is your level of stiffness when you wake up in the morning? And stiffness and pain, not always the same thing. What was your quality of sleep? And then we look at some other measures, and these are tools that measure the quality of pain, intensity of pain. But if you look at the ones that were effective in this trial, you can see that the effect of the Sativex drug, this is the spray, was powerful on morning pain on movement, getting up and moving around, significant reduction. It was an important reduction of pain at rest in the morning, and interestingly, quality of sleep, a nice effect, and then a sort of a global effect on the arthritis syndrome. So sleep, morning pain, and morning movement pain were improved by the use of this medication. It baffles me why this study didn't get reproduced, why nobody else has followed up on this. It never got approved. I really don't understand. Maybe because the side effect profile was quite important. And I think this is something that you need to remember. Cannabis is not a drug that's devoid of side effects. It's not a miracle drug. Look at the side effects: dizziness, lightheadedness, dry mouth, nausea, kind of things that we get with a lot of other medications. So for many people, this is a medicine like all others that has side effects, and learning how to use it wisely to get those side effects. For a lot of patients, these side effects are important, and they won't take the drug because the side effects are not very pleasant. So that's maybe one reason, but I think that dosing, if you take small enough doses, if you learn how to use the drug wisely, you may be able to minimize the side effects. But it's a small trial. Look at the number of patients, 58 patients altogether. That's a small trial. Normally, drug companies do studies with hundreds, if not thousands of patients before they get approval. So we need to do studies like this on much larger numbers to decide just how effective they are. We talked about opioids and the differences between cannabis and opioids. There's some really interesting work coming out now, especially given that we're very concerned about opioids. You'll be aware of the fentanyl overdoses and what's happening with opioids, and people are overusing them, and doctors are overprescribing them, and there are a lot of important problems with opioid prescribing. We're learning that in the US, where they have states that have legalized medical marijuana, that the amount of opioids that are being used in these patients are dramatically reduced. So this was a study looking at patients going to a medical marijuana dispensary in Washington State, where it's legal, and they looked at the number of patients that were using drugs like opioids, anti-inflammatories like Advil and Aleve, disease-modifying anti-rheumatic drugs, antidepressants, and so on, before they started using cannabis, which is the column on the left, and then 6 months later. And you can see in the brackets the percentage. So percentage of patients on opioids, 65% at the beginning, 18% after 6 months. Percentage of patients on anti-inflammatories, 62% when they came in, 21% at the end of 6 months. Disease-modifying drugs, 8 at the beginning, 2 at the end. And this is true for all of the classes of medication. So really big reductions in the medications. I don't know if the patients got better. I don't know if their pain was less, but they were using a lot less medication after 6 months on cannabis. And that's something that I think we're beginning to look at very, very carefully and see if this is really an important thing. So I talked about safety, and it's really my responsibility as a clinician to talk to a patient about what might the benefits be. And I've told you already that I can't say with any certainty that clinical trials show that it's effective. What I can talk to you about are some of the safety issues. And I could spend an hour on each one of these things, but I'm sure if I did a quick show of hands as to what were you concerned about the safety of cannabis, a lot of these things would come up. I'm worried that I'm going to get addicted, that it gets abused, that it gets diverted, somebody else could use my drug. I'm worried that I'm going to get tolerant to it. If I use it, will I develop tolerance and need more and more and more? Do I get dependent on it? If I stop, do I get withdrawals from the drug? What are the effects on the brain? Will it make me go psychotic? Will it stop me from driving? Will it make me more anxious? I have people get paranoid when they use marijuana, and that's an important side effect. Will it interact with my other medications? What are the effects on the heart? Will it affect my heart? But cannabis has a very well-known effect on the heart rate. It pushes heart rate up. And if you know this, the red eyes that people get when they smoke marijuana, that opens up the blood vessels in the periphery. So when you do that, your heart rate has to increase to compensate. And so, if you have a bad heart, this can cause problems. So, you need to know about effects on the heart. If you're pregnant or breastfeeding, we don't recommend it. Weirdly, it can make people very nauseous. And I showed you some medicines earlier that are based on cannabis that actually help with nausea. But some people get this very powerful nausea. They actually smoke marijuana and they get such bad vomiting, they have to go to the emergency room. And there's a weird syndrome called hyperemesis-induced, cannabinoid-induced hyperemesis, where the only thing that helps is taking a hot shower or a hot bath. And we're beginning to see this in emergency rooms more and more now in Canada as cannabis is becoming more available. But it's this kind of strange phenomenon where people actually get worse when they use cannabis, and we're beginning to see a bit of that. People who smoke anything, worried about the effects on the lung, and looking at ways to maybe reduce or minimize that, other ways of using it. And I mentioned some of the concerns about diversion. So we can talk a little bit if any of you have interest during the question period about any of these. There are good data on most of these telling us the kind of the level of the risk, but you should be aware that all of these are concerns when you're going to use a drug you should be thinking about. What we do know is that if you have a history of psychosis, if you had schizophrenia, if you are schizophrenic, if you have a family history of a cousin or a brother who is schizophrenic, you need to be really careful with cannabis. It has been known and shown to unmask in people who have this kind of propensity for schizophrenia to unmask that. So you need to be really careful. If you have an unstable heart, that's what I mentioned earlier. This is really not a drug you should use if it's not well controlled, and of course avoiding it if you're pregnant or breastfeeding. And a lot of doctors, and we're counseling that people sometimes looking for cannabis have a problem with it. They're using too much of it, they're really focused on it, obsessed by it, and this can sometimes be a problem, and you need to recognize that for some people, excessive use of cannabis can create a cannabis use disorder, and you need to be sure, is this a medical issue? Are they coming because they're having a dependency to it and that's what they want repeated prescriptions for, or are they using it to improve their health, which would be more medical? And I like to say that cannabis is the means to health, not the end. It's not about getting marijuana and then it's over. It's about getting cannabis like any other medicine and using it to help you get better, more movement, more active, more functional. And that then is what the doctor is going to be looking for to say that's an appropriate medicine. It's true for any medication. It's what you use it for to get you back to work, back to function, back to moving. That's the treatment that you're looking for. A lot of interest in vaporizing. People are worried about smoking cannabis, of course, because of the effects on the lung or potential effects. And so these e-cigarettes are quite popular now, and you get these vape pens and you can put cannabinoid oils in there. We don't know a lot about this stuff. They're oils that the concentrates that we don't really know. They're not regulated. We don't know what's in them. They use things like naphtha, butane, alcohol, and you're inhaling that into your lung. I can't say for sure if that's safer for you than smoking. I just don't know. And so I counsel you to be very, very aware that these things are not regulated. We don't know where they're coming from. A lot of these are made cheaply out of the country. The plastics that they use, the heat sources are weird. So just be careful of accepting and embracing these kinds of vaporizers without knowing more about them. There is a device, and this company that makes this device, this is an approved medical device for vaporizing herbal cannabis in Canada. This is a large machine. There's one that's quite portable. It's the size of a big iPhone 6. And you can put herbal cannabis in that and vaporize it, and that doesn't burn the drug. It doesn't have the same smell. It doesn't burn the product and cause the toxins that you get when you smoke. But it gives you very similar plasma levels, and the graphs there just show you that it's the same as inhaling it if you were smoking it. So these vaporizers, there are those that are medical devices, and those are the things that you should be aware of if you're going to look at this as an option, that are approved for this purpose in Canada. Unfortunately, the device is approved, but the cannabis that you put into it is not. So The Arthritis Society has done a fantastic job. Okay, perfect. So I'm wrapping up. So a fantastic job putting out a document. I advise you to go to the website, and I'm not sure if these are available freely, but maybe you can tell us. Free on the website. Really good resource. I won't take up more of your time telling us. I really suggest you go to the Arthritis Society site and find this form. What I would advise you is decide why you want to try it. What if you're interested or curious, and I presume you're here because you're curious, what is it you're trying to do? Is it to help you reduce your pain? Is it to help you get out of bed in the morning? Is it to help you sleep? Is it to help you get, move and play around or golf? I don't know if cannabis is good for golf. I haven't tried it, but I know those who swear by it. Is it for medical? But do you want it to relax? Do you want it just to enjoy an evening and sit back at the end of the day, or are you going to use it as a therapy? And I think you need to go through that in your own mind. Talk about it with your doctor. I know there are doctors who are resistant to this. I know there are doctors who don't really understand it. But I think if you're open with them and you ask them and you show them materials and you bring them these kinds of documents, say, this is something I'd like to try. Maybe it'll help me reduce my opioids. Maybe it'll help me get off my, my 8 Advils a day. That's something to think about. And maybe that's a good, good way to start. Consider the prescription, the Nabilone, the Sativex, the ones that are prescribable. Don't be afraid of them. They may be useful. Very small doses may be a valuable thing. And be aware, you've come to this meeting, there's lots of material. Reading these kinds of documents are very helpful in understanding how the process works. In Quebec, if those of you live in Quebec, how many of you live in Quebec? Show of hands. I imagine most of you are Quebecers. So the Collège des Médecins in Quebec insisted that you should only access cannabis through a registry or through a research project because there was no data. So in some ways they've encouraged us. We now have about 800 patients who are registered to use cannabis through the registry with their physicians. So we're helping them get access, but we're also following them over time and learning about how they use it, how much they use, so that we can actually gain some information as they use it to help us understand this better. So you've heard from Jason that there's animal studies suggesting THC and increasingly cannabidiol might have some value in arthritis symptoms. We know that mostly what we know is it's mostly symptomatic. It doesn't change the disease. It won't make the arthritis go away. For as far as we know, it's mostly symptomatic pain, stiffness, spasticity, and so on. Side effects, doesn't work for everybody. It may not work for you. So you should be aware of the fact that this isn't a miracle drug. And we need clinical trials. And to that end, I'm going to shamelessly plug a study that we're doing now at the Montreal General on vaporized cannabis for osteoarthritis of the knee. If you're over 50, you have OA of the knee, and you don't have a BMI of over 50 or over 45, I think it is, you're eligible for the study. I've left some information at the back if you're interested. So there are the criteria. The hospital number is 934-1934, extension 4438. The nurses are standing by for patients to recruit. So call us if you're interested in more information. It's called the Capri trial. And with that shameless plug for doing more research, we're actually doing more research. I'd like to thank you for your attention and take questions. Thank you.
Thank you so much, Dr. Ware and Dr. McDougall. Does anyone have any questions? Yeah, please.
Hello, gentlemen. Is this on? Yeah. Thanks very much for that. Very good two-way kind of perspective on cannabis and how it's entering our lives. I have ankles and spondylitis and psoriatic arthritis, so a lot of the information on there is very, very good. Caution on the, like you were saying about the side effects, and I mean, I use it for those two conditions, but I also, I suffer a little bit from the secondary depression and anxiety, and I find that when I'm using, I got to be really careful during flares on the mental side of it. So bringing that into perspective for me was really good. I guess from a question perspective is the way that I'm navigating through now kind of feels like, for me, I was a little bit pre-biologics too. So, I ended up with a lot of disease through that, and now I'm here and trying to navigate through here. But like you're saying, a lot of it is the THC side. So from a CBD perspective on someone like me, can you maybe give a little bit of tips or guidance on where to go and how to get it safely and how to track it over time.
I'll jump in quickly just to ask you, are you accessing cannabis now through the medical marijuana program, or are you
Yes.
doing it some other way? And I don't think we're recording this, so
No,
please
through-
don't. You're getting it through the medical marijuana program. So some of the licensed producers have high CBD oils and cannabis products. So have you tried those through the producers?
From a CBD perspective, I was more interested kind of in the oral ingestion
Right.
of it, and I'm not sure that they all cover it. I mean, I haven't looked that far. I just don't want to get into it without being kind of careful and cautious.
Well, I don't have clinical data to point to you, and Jason may be able to talk more to the basic science side, but from a clinical standpoint, really talking to the licensed producer that you're registered with, asking if they have high CBD products and if they make an oil that's high in CBD, and then working with them to try that. It's kind of,
Okay.
you're doing this on your own. I think, as Jason said, it's a relatively safe compound. It certainly isn't the psychoactive, anxiety provoking effects of
Right.
THC. So I could reassure you that you're likely it's a much safer option than THC, but in some ways you're kind of on your own to try it by yourself. Jason.
Yeah, so from a science perspective, it's remarkable that there's very, very little work done on CBD. I find it quite astounding. There was a study done around about 10 years ago where they found that CBD was able to reverse or maybe stop the progression of an inflammatory joint disease. And we're starting to do some work funded by the Arthritis Society. Actually, Holly Philpott in the audience, one of my trainees, is working on this, and just hot off the press, just this month we found that CBD in a model of osteoarthritis is extremely effective at reducing joint pain. So we're very, very excited about it, and we've got some more tests to do. Well, Holly's got some more tests to do.
I met her yesterday, so she
Okay.
was fantastic. Thanks a lot, guys.
Thank you.
In our vaporized trial, we've got high CBD, high THC, and then a range of, so we're asking the patients to try different ones and tell us whether they feel that there's a difference in the effect. So we're actively looking at that too. Thank you.
Hello, it was a great. It's my first lesson on cannabinoids. I'm a rheumatologist. I'm already prescribing medical cannabinoids occasionally, and I find it useful, especially for sleep. One comment that you did is very important, that it's a symptomatic drug. It's not something to treat. And we talk about inflammatory diseases. If we only control the symptoms, we let the damage of the inflammation go on, and it may continue this way. And one question I have is not that directly to you, it's more to the Arthritis Society. Unfortunately, it's why did the Arthritis Society become the proponent of medical cannabis with so little scientific support for it, contrary to other, for example, traditional Chinese herbs for which there are evidence that it not only controls symptoms but control inflammation. I don't know. It's just a question. I know there's a lot of work to do there, but why was cannabis? It's because it's in the it's because there's a lot of use of it. We already know there are side effects of it. You talk about the cycle.
So yeah, Gilles, there's patients drove it. It was the patients who were interested and wanted to know more about it. And there is a lot of preclinical evidence, and I don't accept that cannabinoids are just there for treating symptoms. I showed you that today. They're anti-inflammatory as well.
Do you have any evidence in clinical practice for it?
No, not in clinical practice. Yes, sure. This is something that Mark and his team are going to look into. So, and again, some of those cannabinoids can reduce and reverse, as I said, the disease process itself. So people have been focusing, and quite rightly so, maybe to some extent, on the symptoms, on the pain relief. But there's more to it in this plant than just simple symptom relief. Sure.
Janet Yale, president of the Arthritis Society. I just want to pick up on Jason's point. We do not endorse or promote any therapy. That's not our job. And so I think it would not be accurate to say that we promote people using medical cannabis. What we have said, as Jason pointed out, is that if you look at the regime that was in place by Health Canada, over 60% of people who used medical cannabis did it for the alleviation of arthritis pain. So the vast majority of people who use medical cannabis do it for the alleviation of arthritis pain. And based on that, we said, given the lack of evidence, that we would help. Our position started as, how can we help fill that evidentiary void by investing in research and by making it clear for people who wanted to use it, not that we were advocating its use, how you would access it. So that guide to access does not encourage people to use it, but because you can't get a prescription, as Mark pointed out, you need an authorization. So we explain how the authorization system works and how you use that authorization to get a mail order supply from a licensed producer. So that really is our fundamental view, is that for people who want it, in consultation with their prescribing physician, that they should be able to access it. And in the interim, we are really proponents that there has to be a massive investment in research, and there are some reasons I don't have time to get into as to why the pharmaceutical industry hasn't invested in research, which has to do with the inability to monetize it in the traditional chemical or biological formulation manner. So I just wanted to clarify that that's the logic and rationale for why we're involved.
Hi, thank you for all the information that you gave today. I suffer from fibromyalgia, and with my physicians, I've tried multiple types of drugs, antidepressants, opioids, and so on. And my physician is completely against even considering the conversation of cannabinoids or cannabis, and I've tried to talk to her about it multiple times. And so my question, I guess, is I've tried the difference using 6 months at a time or a year at a time, different medications versus cannabis, and I don't get it through the registry. And I would like to, because I would like to have the right dose, the right type, to do what's better for me to reduce my pains and to be able to work out, go to work, and sleep well. So my question is, how do I go communicate with my physician, or where do I find a physician that can communicate, that I can communicate and work with to get more information or access?
That's a question that's being asked all across the country, and it's challenging because I mentioned right at the beginning the stigma of the drug, the lack of evidence. There are multiple barriers. It's an illegal substance to possess if you don't have an authorization. So a lot of clinicians are concerned that they're acting as the gatekeeper for somebody who is wanting access and can want to ask about cannabis. They don't know how to be sure if it's because they want it just to be using it recreationally or they really want it as a medical therapy. And that's a conversation that we have to have over and over again as experts and researchers with clinicians, trying to understand what are the barriers that you have and how can we address those. The big one is research. I mean, you heard it here already. The lack of evidence is a big thing. So if we can do the study, the astonishing thing is when I'm doing studies on on osteoarthritis, fibromyalgia, I can't even get rheumatologists to refer patients for the studies. So while they don't necessarily want to have the discussion because of a lack of evidence, there's also a barrier to actually sending patients in to do the clinical trial. So this is a really deep sort of societal issue that we're trying to change the perspective and the way people think about cannabis. And yet there's an ease to prescribe other things for, even though they may not have as much evidence either. But the challenge is keep having the discussion. Don't be combative. This is not an area where we need to fight each other. We need to work together. We need to sort of understand what those barriers are. Try and reassure people that things can be done in a monitored, safe way. And if it doesn't work for you, you stop it. It's not, if you try it for 2 or 3 months and it doesn't work, you stop and move on to the next thing. But I think it's the kind of thing that that we need to promote. And at least I've spoken to patient groups many times, and I've asked if those of you would be interested in being in research studies, and almost unanimously they put their hand. Fine, I'll do it. If I can help contribute to the research base, I'll do that. So I can't give you a specific answer. All I can do is advise you is be a patient. don't be combative. Try and work with your physician and see if you can use it to, get that more exercise, more off your other medications. There may be ways to have the conversation, but work with them if you can.
That wraps up this session. Thank you so much to our speakers, Dr. McDougall and Dr. Ware, and for your thoughtful comments as well as your insightful presentations. I'd also like to thank the sponsor for the session, Bedrocan, and invite all of you to fill out a comment card, which I believe is at the back of the room. Thank you so much and have a great rest of the day.